Okay, one of the last ones in this series is the lecture on drugs used to treat dyslipidemias. So this is the one for all of your your anti-cholesterol meds and things like that. That's what your patient will call them. So atherosclerotic disease is a major cause of premature death in the United States. Atherosclerosis is the accumulation of fatty deposits on the inner wall of the arteries and arterioles throughout the body. Hyperlipidemia is a broad term used to classify patients with high levels of cholesterol or blood fat. Antilipidemic agents are used to treat hyperlipidemias. Lower LDL, typically bile acid binding resins are used, so if we want to lower the LDL. For triglycerides, to lower the triglycerides, typically we use fibric acids, and niacin is typically the most effective way to raise the HDL. Remember, HDL is good, LDL is bad. We want low LDL, high HDL. Typically statins are used first because of their safety and because they've been used long enough that they've become cheap in the generic form. Your assessment, you check for elevated serum lipid levels, risk factors of obesity, smoking, dietary habits. Patient education is typically about lifestyle changes along with the medications and following their medication regimen and what kind of follow-up care they may need. So bile acid binding resins. The biggest one out there is cholestyramine. These aren't used that much anymore, but you still will have some patients on it, so it's good to kind of know about these. Their MOA, or mechanism of action, is that they bind bile acids in the intestines, which makes the liver increase metabolism of cholesterol, thereby decreasing the total cholesterol in the body. They're used in conjunction usually with diet therapy. So if your patient is good diet controlled and is going to cut down on their fat intake. Adverse is mainly gastrointestinal, may cause some constipation and bloating. Nursing considerations, they will decrease the absorption of amiodarone. So typically patients who are on this do typically have some kind of heart problems, so we got to watch amiodarone, and we need to administer it 1 hour before other medications or 4 hours after the other medications have been given, so that we know that the other medications have been digested and absorbed the way they should and metabolized. They also reduce the absorption of fat-soluble vitamins, so that may be something that you need to talk to your patient about. Niacin. Mechanism action is not completely known. We do know that it inhibits the LDL synthesis or VLDL synthesis by the liver. Uses are typically to decrease cholesterol concentrations. And again, this does it by increasing the amount of HDL. Adverse effects, you're going to have some hepatotoxicity and myopathy and anorexia. So we're starting now to get into the medications that we're going to have to do a little bit more testing and make sure the liver's working, make sure that we don't have any kind of muscle problems going on. And remember, the definition of anorexia, it's not what you think of as the anorexic who's not eating, that's anorexia nervosa. This is anorexia, which is just the loss of an appetite. Nursing considerations, you need to check the triglyceride and cholesterol levels both before and during, and of course we need to recommend that there be some liver function tests, and if we see something going on with the liver, we need to let the provider know. We also need to be informing the patient of how to know if something's going on with the liver, so again, those signs and symptoms of jaundice and those types of things. HMG COOA reductase inhibitors, the most potent of agents available. These are known as the statins. So these are the ones that are out there. Atorvastatin is the biggest one. Okay. Mechanism of action is to completely inhibit the enzyme that is responsible for converting HMG-CoOA2 cholesterol, so it decreases the elevated cholesterol concentrations. Again, you have those same adverse effects you had with the niacin. You have hepatotoxicity, you have myopathy, you have rhabdomyolysis. That's a big one. Statins will cause muscle breakdown. So this is very important as nurses, that we need to teach our patient who are on statins that if you feel any muscle pain, any cramping, anything going on that wasn't there before, you need to let us know, because we probably need to take you off. Because again, the heart is the biggest muscle we have, or the most important muscle that we have, and it is a muscle. So if other muscles are breaking down, possibility that the heart muscle is breaking down, and that is not good for your patient. So we're going to do a lot of education on that. Other nursing considerations are that it may cause patients on warfarin to bleed longer, so it is going to kind of affect that PT-INR. We do need to make sure our patients understand that. They know what bleeding precautions are. They know how to let us what to do if they are bleeding. No grapefruit juice if they're taking atorvastatin. And then we have to teach the client to report any muscle pain that they may feel. The fibric acids. Fenofibrate is probably the biggest one that you'll see a lot of. It's the most effective triglyceride lowering agent. The mechanism of action is unknown. It is used to decrease triglyceride levels. Your biggest adverse effects are fatigue, anorexia, and that myopathy, again, that muscle breakdown. And again, remembering that it may enhance the pharmacological effects of Coumadin or warfarin, and it's also going to enhance the effects of insulin. So if you have a diabetic patient who is taking insulin and getting this, we really need to closely monitor those blood sugars. So there's going to be lots of patient education again for these patients. Excuse me. Commonalities between all the medications are typically your labs. We need to be looking at serum triglycerides, serum lipoproteins, serum cholesterol levels. Liver function tests are going to be important. The fact that we need to tell our patients to report muscle pain. Again, this muscle pain, if it's new and it's not because they've started to work out and that type of thing, we need to worry that we have muscle breakdown going on, which could affect the heart. They need to report the muscle pain, like I said, and lifestyle changes. We don't want to preach that just take this medicine and everything will be fine. We want to teach that the medicine is there to help, to enhance, but that we probably need to change our diet and not eat as many fatty foods, and there probably needs to be some working out and that type of thing going on. So lifestyle changes. If they're smoking, we're going to ask them to stop smoking. And what can we as nurses do to help that? Instead of just saying stop smoking, can we get them in a program? Can we get them nicotine patches, those types of things? So those are the things that we will look at.